Welcome to LACNETS. I'm Joanna Morales, and this is our September 2015 meeting. Many of us have struggled with some kind of legal issue in our cancer journey. Being diagnosed, whether it's financial issues, learning about disability, insurance questions, things not being covered. And I know in our group we've got a lot of questions about, well, why is this being covered for this person or not for this person? Or I went out of the country, how do I get this procedure covered? Things that are still in clinical trials but available in other locations. So, and a few years ago, Joanna Morales, who is with the Cancer Legal Resources Center, came and spoke with the group, and we're very fortunate to have her back now, and she started her own organization called Triage Cancer, of which she is the CEO. So please welcome Joanna Morales.
So I'm going to give you kind of an overview of some of the new health insurance options, consumer protections that are available in health insurance coverage across multiple types of health insurance, and then we'll talk a little bit about finances. How do you avoid certain types of medical bills? How do you deal with paying medical bills? Options for financial assistance. So there are actually a lot of things that can affect your finances, and today, again, I'm just going to focus on health insurance, some of those consumer protections, making sure you have adequate coverage, and then we'll talk really briefly about disability insurance and then some additional financial assistance options. So this can sometimes be a dry subject of health insurance coverage, but it can also be ironically funny. So this is a gentleman talking with his health insurance company representative, and the representative says, "I'm sorry, but stress caused by trying to figure out your health insurance is not covered by it." And that is a familiar feeling. All of us have challenges navigating our health insurance coverage, and I think really I always say that we should have a class in high school on health insurance, because otherwise why would you know any of this information? And the fact is that the majority of people in the United States don't know anything about their health insurance coverage or the healthcare system. And then we got these new changes to our healthcare system, and so it's been really difficult to try to explain the changes because no one understood what we had to begin with. So we're going to talk through some of those things, but the first thing I want to start out with is some terms. Not only because I'm going to use them throughout the presentation, but they're things that you should know about your health insurance coverage. It's incredibly important that you know these things. So the first is there are costs that we have to pay just to have health insurance coverage. And this is typically our monthly premium. So it's an amount of money we pay each month just to have coverage. Even if we don't go to the doctor all year long or get any type of medical care, we still have to pay our monthly premium every month just to have the coverage. But then there's costs that we're going to pay to just get medical care. And there's different types of costs. So the first is our deductible. And it's usually an annual deductible that you pay once a year. And it's a set dollar amount that you have to pay first before your health insurance coverage kicks in. So if you have a $500 deductible or a $5,000 deductible, it could be that based on what type of coverage that you have. And then there's something called a copayment. And that's a fixed dollar amount that you pay each time you go and get certain types of medical care. So for an office visit, you may have a $20 copayment to see your doctor. Or if you go to the emergency room, you might have a $200 copayment if you go to the emergency room. But then there's something called coinsurance or cost share amounts. And these terms are used the same way, but it's the difference between what your insurance company pays for your coverage and what you pay for your coverage. So when you go and get medical care and you have an 80-20 plan, that means that your insurance company is going to pay for 80% of your medical expenses, and you're going to be responsible for 20% of your medical expenses. So Medicare is a good example of an 80-20 plan. So you're still going to be responsible for the 20% that Medicare isn't going to pay for. And then there's something called an out-of-pocket maximum. And this is probably the most important thing that anyone should know about their coverage. It's a dollar figure that when you reach that dollar figure in medical expenses that you've had to pay out of your own pocket, your medical coverage will kick in at 100%. So if you have an out-of-pocket maximum of $5,000 for the year, once you hit $5,000 in medical expenses, even if you have an 80-20 plan, your insurance coverage is going to kick in at 100% instead of the 80%. So you want to know what your out-of-pocket maximum is, because once you get there, you don't have to pay out of pocket anymore for your medical expenses. So, and it's actually a math problem. So to get to your out-of-pocket maximum, you get to add up what you pay for your deductible, what you pay for any co-payments that you make during the year, and any of your co-insurance amounts. So to give you an example of why this is important, imagine you're in a car accident and you spend a week in the hospital, and you walk out of the hospital with a $102,000 hospital bill. What do you actually have to pay of that bill out of your own pocket? So if you have an 80-20 plan that has a $2,000 deductible and a $4,000 out-of-pocket maximum, again, what do you pay? So you pay first the $2,000 deductible, so you still have $100,000 left of the bill. So what do you pay of that? Well, your insurance company is going to pay 80%, and you're still responsible for 20%. So they're going to pay $80,000, but that's still $20,000 of that bill that you're responsible for paying. So how much do you actually have to pay of that $20,000? It's actually $2,000 because you've already paid the $2,000 deductible, exactly. So imagine if you have that $102,000 bill, you're only paying $4,000 of that bill total, assuming you've had no other type of medical care during the year. So in a worst case scenario, it lets you sort of plan around what you would have to pay out of pocket for your medical expenses, which is why it's an important dollar figure for you to know, and also keep track. Now, your insurance company also keeps track every time you get an explanation of benefits from your insurance company, whether it's Medicare or private company. It can include information like that. So you also want to be paying attention yourself to make sure that they've accurately reflected what you've had in medical expenses throughout the year. So I mentioned before that people don't really understand their health insurance coverage, and that's not just my opinion. There's actually been some research to that effect, and this was actually a study that was released in January of employees who got health insurance coverage from their employer. So they get coverage, but they have no understanding of how it works or what to do with it. And so that's just people who have insurance. They don't know how to file a claim. 44% don't understand their deductible. So there's actually only 3 places you can get health insurance coverage in the United States. You're either getting it from your employer, from a private insurance company, or from the government. And that would include things like Medicare, Medicaid, state health insurance plans, veterans health. Those are things that you get from the government. So there's only 3 places that you can go for coverage. So I want to talk a little bit about employer-sponsored coverage. Because COBRA is still relevant even with the changes to our healthcare system. If you get coverage through your employer and you leave your employer or you meet some other type of qualifying event, you can actually keep the same coverage that you had when you were employed for an additional period of time. So in California, you actually get to keep your COBRA coverage for 36 months regardless of the qualifying event because we have a state law that allows for that. But the downside to COBRA is that you're paying the full amount of what your employer was paying for your health insurance coverage. And I always say we don't appreciate what our employer pays for our coverage until we have to write the check ourselves. But it is a way to keep coverage if you don't have access to coverage in another way, or if your coverage is really good and covers your providers and your prescription drugs, then you don't have to worry about finding a policy that does, because you can keep it. So I know that there are a number of people in the room who have questions about Medicare or who are on Medicare currently. Medicare is one of the 2 federal health insurance programs available. So Medicare is only available for individuals who are 65 or older and eligible for Social Security retirement benefits, or who've been receiving Social Security disability insurance benefits for 2 years, so they're on SSDI for 2 years, or if you have end-stage renal disease or ALS. Those are the only ways that you qualify for Medicare. So not anyone can apply for Medicare and see if they qualify. These are the only ways you get access to the Medicare program. Now, the Medicare.gov website is very useful. So I wouldn't normally have said that, but about 6 or 7 months ago, they did a revamp of the entire Medicare website, and it's very user-friendly now, and you can actually find the information that you're looking for. And so when you're making choices about what type of Medicare you want to have, or if you have questions about coverage, or if you're looking for a prescription drug plan, or you're looking for supplemental Medicare insurance, you can actually do all of that on the website now, which you really couldn't navigate before. So it's a very useful tool. The other useful tool for navigating Medicare is actually a booklet that they release every year called Medicare and You. So if you're on Medicare, it should be mailed to you every year. I've given you the link for the 2015 book, but I think the 2016 book is now out because we're going into open enrollment next month. And every year at open enrollment, you can switch the type of Medicare coverage that you have. So there's two ways to get access to Medicare, or to choose your Medicare coverage. So there's original Medicare. And original Medicare refers to Part A, Part B, and Part D. So I'm going to explain that. So Part A of Medicare is hospitalization insurance. It only covers your care when you're hospitalized. Part B of Medicare covers almost everything else except prescription drugs. So it's really the meat of Medicare coverage. It's your office visits and your lab tests and your scans and your durable medical equipment and some chemotherapy. So Medicare Part B really covers a lot, but Medicare Part B costs something. So if you're eligible for Medicare, most people get Medicare Part A for free because you've paid into the retirement system and you've paid Medicare taxes. Part B comes with a premium. So you have to pay a monthly premium for Medicare Part B. So even though when you become eligible for Medicare, they give you A and B automatically, they give you a choice to decline B, to say, I don't want B. And a lot of people say, I don't want B because they have to pay for it. But then they find out that that actually is what covers everything. If someone does that and doesn't take Part B when they're eligible for it, you pay a lifetime penalty if you want to get it back. So it's really important to read the fine print and to pay attention when you become eligible for certain things. So Medicare Part A covers hospitalization. Medicare Part B is really medical insurance. But then in 2005, we got prescription drug coverage through Medicare, which we didn't have before. And that's called Medicare Part D. So Medicare Part D is a separate policy entirely. So you get A and B, but then you have to choose a Part D plan. And I said that that's actually something you can do on the website now, so it makes it a little bit easier. You can put in your zip code, you can put in the prescription drugs that you take, and it can sort the plans for you and help you kind of make some educated choices about which plan is appropriate. But you also pay a premium for the Part D plan. Now, Part D plans can range from $5 or they can be $55. It depends on the plan that you choose or the coverage that you need for that plan. Now, you can choose Part A, Part B, and Part D, which are all fee-for-service, which means that you can go to any provider that takes Medicare. So it gives you choice. However, if you choose Medicare Part C, which is a Medicare HMO, you're limiting your choice by saying, I'm only going to go to providers within the network of that particular plan. The positive side of Part C is that sometimes it costs less. So sometimes Part C plans will pick up the monthly premium for B, and they'll pick up the monthly premium for your Part D plan. So a lot of people choose Medicare HMOs because it's a lot cheaper, and if their doctors are covered, then that's a good choice for them. So you have to figure out what's actually the better option for you, but you do have choices. But once you choose one path, you have to stick with that path for the whole year. But then every year at open enrollment, you could switch. So there are reasons you might want to switch. So if you know that you need surgery in 2016, but right now you're in a Medicare HMO, but that provider that's going to offer you the surgery is outside of your HMO's network. You might decide for 2016 to move out of your Medicare HMO and just take Medicare fee-for-service for 2016. But then if you wanted to go back to your HMO, you could do that for 2017. So this goes to some of the questions that we were talking about a little bit before we started about why you would, if you wanted to go outside your network to get care, like to participate in a clinical trial or to see a specialist in a particular type of cancer or particular type of procedure, there'd be a reason that you might want to switch out of your Medicare HMO to go to fee-for-service. Everybody's automatically given original Medicare, and then you can make choices. So typically you get a 7-month window to make choices for Medicare. So it's if you were turning 65, it'd be the 3 months before the month that you turn 65, the month that you turn 65, and then 3 months after. So they give you a 7-month window to make choices about Medicare. And it's the same thing really when you qualify for disability benefits. So I told you before, Medicare is an 80-20 plan. So Medicare covers 80% and you are responsible for 20%. In addition to that Part B and Part D monthly premium, if you have original Medicare. Something that people do is they buy supplemental Medicare insurance that picks up that 20% and covers things that Medicare doesn't cover. Eyeglasses and dentures and some of the other things that maybe Medicare wouldn't cover are covered by Medigap plans. So they don't make it easy for us. They call everything the same thing. So Medigap plans are picking up the gaps that Medicare doesn't cover plus the 20% out-of-pocket cost. So there's different lettered Medigap plans, just to make it confusing for us. So there's Part A, Part B, Part C, and Part D. Those are all original Medicare plus your Medicare HMOs. And I apologize I don't have slides to this, but I knew that you had Medicare questions, so I wanted to cover some of this. Medigap plans are those supplemental plans. If you're interested in looking at the Medigap plans that are available to you where you live, then again, the Medicare website is a great option for that. So you can go to medicare.gov and it asks you about, I think it's called, the tab is choosing health plans, and there's a tab for supplemental coverage. So you can put in your zip code and it shows you all the Medigap plans that are available to you. And they're laid out in a chart. So all Medigap Plan A's cover the same thing. All Plan B's cover the same thing. All Plan F's cover the same set of benefits. So you choose your set of benefits and then you choose the company that's offering those benefits, and you want to look at the price of what those companies are offering you. So it's a lot of choice, and it puts the burden on you as a consumer to kind of figure out what applies to you specifically. But the flip side of that is that you have a lot of choice and you can figure out what applies to you. And again, on that Medicare website, the tool for doing that is very simple and to walk through. It walks you through the whole process. So are there other questions that I can speak to about Medicare? That's actually a fantastic question. So the question, for those of you who might be watching this later, was related to her specific coverage. Now, a lot of people opt to have their Part B premiums automatically withdrawn from their Social Security payments every month. That's pretty common. With respect to your Anthem withdrawal, without kind of seeing your policy and seeing your cards, it'd be a little difficult for me to say, but what it sounds like is that you have an Anthem health insurance policy in addition to Medicare coverage, right? But it's not a supplement. So if you have, okay, let's say for example you were working, and then you turn 65, and you become eligible for Medicare, but you still have a coverage through your job. So you're still working, but you become eligible for Medicare based on your age. If you were to leave that job or retire, then you could still get access to that employer's coverage through COBRA or through a retiree plan. So you might have Medicare plus have a private health insurance plan. That's also very common. So if you have Medicare is probably going to be your primary, so it pays first, and then your additional coverage is going to pay second. That's totally different than having Medicare and buying supplemental Medicare coverage through a Medigap plan. So it's just a different way that you're getting access to insurance coverage. So what it sounds like is you have that Anthem Blue Cross plan that isn't a supplement plan, it's just another private health insurance plan, and that it's also giving you access to prescription drug coverage through that plan. So without actually seeing your policy or being able to see your card, I couldn't answer specifically, but I'm happy to talk with you after about that. But it brings up a good point of the challenge with all of this, it's like a big puzzle piece, right? So you're trying to figure out how you get these different pieces of coverage to fit together to work for you to cover as much of your expenses as possible. And sometimes you have multiple options available to you, and figuring out which one's going to cover the most of those out-of-pocket expenses is going to be your challenge. But again, if you're eligible for Medicare now, you're going into the open enrollment period for 2016, so it's a good time to start looking at, even if you've been happy with Medicare, the coverage that you've had in the past, it never hurts to look at your options to see if maybe you would be paying less, or there's a plan, Medicare supplement plan, or a Medicare Part C plan, the Medicare HMO, that's going to cover more of your expenses. So it never hurts to look to see what your options are.
I just want to add one last thing, then I won't say anymore. But just so people understand when they're on Medicare, that the price that we pay, and I think we gave it when we're planning for when we get of age. If you had employers take care of it up to then, and we were self-employed, so we paid a lot more. But we pay close to $800 a month on insurance that we have that is Medicare and our supplement. And that's just something to keep in mind as you're planning, that you have to have that in mind as you're planning what you actually need for retirement. And I can't help but tell people that it isn't a free privilege or right or something. You pay that much money for it.
Absolutely, and that's a very good point. I think a lot of people assume once you get to Medicare that it's all going to be free, and it's not. There are out-of-pocket costs associated with Medicare, whether it's your annual deductible or your co-payments or your 20% co-insurance amount, and there's different deductibles for your medical expenses and for your prescription drug expenses. So all Part D plans have different deductible levels. It's capped, but depending on the plan that you choose, you might have a $0 deductible but pay a higher monthly premium, or you might have a higher deductible and a lower monthly premium. So those are all choices to make. Giovanna?
Just a quick question. My understanding is that Medicare only covers us in the United States. So if we travel, what options do we have?
So if someone is traveling and has Medicare or private insurance for that matter outside of the country, there are limitations on what is going to be covered by that particular policy. Because if you're going outside the country, typically you're going outside of that insurance company's network. Even if it's a PPO, it's still probably going to be outside the network of the PPO. So if you have an emergency and have to go to an emergency room in another country, that's typically covered by your policy. But if you want to get medical care outside the country on an ongoing basis, that's typically not going to be covered by your insurance company. Now, it's slightly different when we talk about clinical trials or very specialized access to care. So in that circumstance, you're going to have to make an argument about whether or not the care that you're asking to be covered is medically necessary. So this applies if you're going outside of California the same way that it does outside of the country. So if your network is Southern California and you want to go to Northern California or Nevada or Washington, D.C. or Paris for your medical care, you're going to have to make the same type of argument. You're basically asking for an exception. You're asking your insurance company to make an exception based on their rules for them to actually cover your care. It's the same thing with Medicare as with private insurance. And to make that argument, you have to argue that it's medically necessary and that you can't get access to that same care inside your network. So there isn't a specialist who has ever done that surgery before inside your network. There isn't someone who is performing that particular clinical trial inside your network. So all of these things are ways to shape an argument, but the best thing that I can recommend is to engage your healthcare team, because it's not the first time they've ever come across this issue. And so figuring out if they have research studies that back up that research study is relevant for your particular medical condition. If they have examples of other insurance companies that have covered that care, that actually can help. Or if you have private insurance, if you can show that Medicare has covered it in that example, that's also very helpful, because a lot of private insurance companies base what they cover on what Medicare covers. So there's no bright line rule, there's no easy answer. It's about making your best argument so that you can go outside the network and have the insurance company cover it. So there's always a difference between, can I get that care? Can I get my insurance company to pay for that care? And can I get it totally and completely free with no out-of-pocket costs? So those are three entirely different things. And so you can still get access to that care if you're willing to pay for it out of pocket, but if you want your insurance company to pay for it, you have to make that argument within their rules. Now, California, as does almost every state, have a specific agency set up to help people navigate their health insurance coverage. California actually has two agencies. We have the California Department of Managed Healthcare, which oversees all HMO plans and all Blue Cross and Blue Shield plans. Then we also have the California Department of Insurance, which oversees all other PPO plans. Now, there was just an article that I read this morning about how our state elected officials are arguing that we should merge those two entities, and there should just be one insurance regulator for the state to make things more streamlined and efficient, and there's a good argument for that. But for right now, we have the two different agencies. And for Medicare, we have Medicare. So the appeals process for Medicare is entirely separate. If there's anyone who's on both Medicare and Medi-Cal, which is our Medicaid program in California, there's an entirely separate process for people who are both eligible for both of those programs. But the process is generally the same. You're asking for them to make an exception and to pull together as much information as you can to back up your argument for making that exception. If you have private insurance in California and your insurance company says no for whatever you're asking them to do, you go through their internal appeals process. So typically on the denial letter, it will say in fine print on the back somewhere, if you want to appeal, this is what you have to do. And usually you just have to write a letter or send in a form back to them saying you'd like them to look at the decision again. And if they come back and say no again, sometimes there's another process internally, or another step internally, but once you've exhausted all your options internally inside the insurance company, you can actually go outside your insurance company to a process that's called independent or external medical review. So you can ask someone who is entirely not part of your insurance company to look at what you're asking for and see if it's medically necessary. And if they decide that it's medically necessary, that decision is binding on the insurance company. The insurance company has to pay for it. So it was to eliminate any sort of bias that the insurance company might have and sort of take the money out of the decision, and to just focus on whether or not that treatment or procedure is medically necessary for a patient. So the question was, will Medicare pay if you want to go outside the country? And unfortunately, this is the most legal answer I'm ever going to say to you, is that it depends. So it depends on what you're asking to go out of the country for. It depends on whether or not it's medically necessary for you. It depends on whether or not you can get someone to approve it. So that's part of this challenge, and actually why the law comes into play is it's about making your best legal argument for why they need to cover this particular treatment if you have no access to that treatment inside the United States and it's medically necessary for you to get that care. But it's still ultimately going to be up to them whether they approve it or deny it. And in some circumstances, they approve it, and in some circumstances, they deny it. And then, unfortunately, there's no hard and fast rule. So it's about kind of working within the system to make it work for you. Triage Cancer is a nonprofit organization that provides information on all types of cancer survivorship issues, and we do that nationally. We provide very specific services. So we host educational events around the country. We host a speakers bureau of experts in different areas of cancer survivorship. So if someone is hosting an educational event like this and is looking for a speaker on a particular topic, you could be connected to that speaker. And then we also have a resource website with state-based resources, an educational blog, and we cover topics across the cancer survivorship spectrum. So there are attorneys across the country who focus on insurance denials. If you are at a point where you feel the need to actually file a lawsuit against an insurance company to get coverage for something, there are some attorneys that I know that I'd be happy to send you their information. But ultimately, you have two ways to go. You have the regulatory process so that you can actually appeal through the appeals process, as I mentioned, or you can file a lawsuit. But filing a lawsuit doesn't necessarily guarantee that you're going to get coverage. And it's the same argument. If you're going to file a lawsuit against an insurance company to cover something, you actually have to make your best legal argument as to why they have to cover it. Now, with Medicare, it's a much different process specifically because there is a specific appeals process through Medicare, and then ultimately you have a court of appeals that you can appeal to. There isn't that external medical review process in Medicare. So even if you're appealing internally or externally or through a lawsuit, you're still going to have to make the same legal argument. So it doesn't, I don't have the greatest answer for this because there isn't a good answer for this. You just have to make the best case for why the insurance company has to cover it. Now, there are certain things insurance companies have to cover. So there's 10 categories of essential health benefits that insurance companies have to provide. But if you're asking for a clinical trial or a specialized treatment that isn't approved within the United States, that's a different game entirely. Because if the care isn't approved in the US, you actually have to go through the FDA's process as well. Because even if you can make the argument that the care might be medically necessary, it still has to be legal. And that's another layer on top of this conversation. And I'm generalizing a bit because there's lots of different, I know people have lots of different types of insurance and Medicare coverage in the room, and so there's different processes for each. But ultimately, going outside the country for care is going to require more creativity. So it's about making the exception requests. It's about going through the appeals process. But I would also argue that you can look at more creative options. So if it's care that just isn't being provided in the US, but is legal in the US and has been approved by the FDA, you might want to engage a healthcare team, so a particular doctor, for example, or a cancer center to actually offer that arm of the clinical trial at that location, or be willing to work with a doctor overseas who will provide your doctor with the drug so that doctor can administer it as part of the clinical trial arm. So there's maybe some ways that you can be more creative, but again, the first step, no matter what I would tell you to do, is you have to talk to your healthcare team. You have to talk to your healthcare providers, to your doctors, and say, I'm having trouble with this. How can we work together to actually get coverage? How can we get access? So if you are going overseas for care but don't have anyone locally who is overseeing your care, that's a little bit more challenging. But even talking to a primary care physician about what the options are would be a first step. So those would be my first suggestions. I think my suggestion of last resort would be looking at insurance lawsuits, but that might be appropriate based on where you're at and what type of insurance coverage you have. I'm sorry, but I don't know off the top of my head if it's currently effective in California, because I feel like they just passed that. So the effective date is not, usually if a law passes in 1 year, the effective date isn't until at least the next year. So I don't think, and the dates are foggy in my head, but I think it was passed in 2015, and so it wouldn't probably go into effect till 2016, but sometimes they make exceptions and they have like emergency provisions where a law will go into effect earlier. So I don't want to say, but I'm happy to look it up and share it with you by email if you'd like.
Could you explain the concept of it, please?
Sure. So the idea of right to try legislation is kind of how it sounds. So it gives you the right to actually try a particular drug if it meets certain circumstances, like if there are no other options that are available to you based on your medical condition. It allows you to try a particular drug that maybe wasn't approved by the FDA for that particular condition. And other than that, I don't know the specifics of the California legislation, but I'm happy to actually write up a summary for you and share it with the effective date. So let me move on a little bit to Medicaid. Prior to January 1st of 2014, there were only a few ways to get access to the Medicaid program, and in California we call Medicaid Medi-Cal. You had to have a low income level, a low asset level, and meet some other category of eligibility. And one of those categories of eligibility was actually called the Aged, Blind, and Disabled program, which is probably the worst name for a program ever. But if you are a senior over 65 and are on Medicare, you could also get Medi-Cal, which would pick up a lot of the additional costs related to your medical expenses based on your income level. Also, if you have a disability under Social Security standards, that would be one way that you would get access to Medicaid. And that's often what we would see in the cancer community, is people getting access to Medicaid if they could show that they have a disability. But if your disability doesn't rise to their standards, then you wouldn't get access to this coverage. So it's actually a barrier. And it wasn't just a low income level, you also had to have a low asset level. And it's very low. It's $2,000 for an individual or $3,000 for a couple. So if you had a retirement plan or a cash life insurance policy or anything of value, then you wouldn't get access to this coverage. Now this was prior to 2014, and we'll talk about how it's changed since then. But ultimately, it's been hard for people to get health insurance coverage because of a pre-existing condition. And pre-existing conditions can certainly include cancer, but they can include things like allergies or asthma. I had a woman tell me once that her daughter couldn't get coverage because she had severe acne. So it was a significant barrier to getting coverage if you wanted it. But also, health insurance coverage is expensive, but it's also confusing. So I showed you the stats about how many people don't understand their health insurance coverage even when they have it. So I put in health insurance into Google and got back 1 billion results. So how do we as consumers even start to figure out what our options are, or how to navigate our health insurance coverage if that's the best search tool we have and it's not actually going to provide us with any valuable information? Also, we know that in the United States that 62% of all bankruptcies are based on medical debt, which is high. But what's scary about that statistic is that 78% of the people that had to file bankruptcy actually had health insurance coverage. So if that many people had health insurance and still had to file bankruptcy because of their medical bills, our health insurance and our healthcare system isn't working the way that it's supposed to. Why else do we have insurance except to not have to file bankruptcy if something were to happen to us? So that was what brought about the conversations related to healthcare reform, and ultimately what that gave us was the Patient Protection and Affordable Care Act, which is also known as the Affordable Care Act, or the ACA, or Obamacare, or healthcare reform, whatever you want to call it. All of those names mean the same thing. It all applies to this particular piece of legislation that's actually been in effect for over 5 years. Now, I'm just going to tell you some of the things specifically that have had an impact on the cancer community that came from the ACA. So the first is that there were some consumer protections that were created by the ACA. So the first is that insurance companies can no longer cancel your policy when you try to use it. So that sounds like something that wouldn't happen, but it was happening so often in California that the LA city attorney filed lawsuits against a number of major health insurance companies, and what they found is that they were paying bonuses to the employees who could figure out how to cancel your policy and not cover you. So that's no longer allowed. Insurance companies can't cancel your policy unless you commit fraud on the application. So don't do that. So the second thing that the ACA did was eliminate lifetime and annual limits on policies. So this goes to your question earlier. Insurance companies are not allowed to put a cap on your benefits anymore. So they can't say, once you reach $1 million in medical expenses, that's it, we're done with you. That's not the case anymore. And this really, some of these things really speak to that bankruptcy statistic, because with cancer care, it's not hard to get to $1 million in medical expenses. And then you have to pay for everything else out of pocket for the rest of your life because you couldn't get insurance because you had a pre-existing medical condition. So all of these pieces really had a big impact on the cancer community. The third thing that the ACA did was say that young adults can stay on their parents' health insurance plan until they turn 26. So we know that young adults have been chronically uninsured or underinsured, and previously they'd have to be a full-time student or a dependent under IRS standards to get access to their parents' coverage. And that's actually no longer the case. It's just based on age. So even if that young adult were married, they could still stay on their parents' plan as long as they're under the age of 26. And what we saw is in the first 2 years that this was in effect, we saw 3 million young adults get access to coverage that wouldn't have had it otherwise. And then the last thing I want to mention on this slide is that California actually had this law first before the ACA passed it. So it has less of an impact in California, but it's important for you to know that this law exists. So insurance companies are actually required to cover any routine costs of your care when you participate in a clinical trial. So what was happening before is that if you wanted to participate in a clinical trial, the insurance company would kind of wash their hands of you. They would say, if you want to do that, then you've got to pay for everything related to that clinical trial out of your own pocket. But that's no longer the case. Insurance companies have to pay for anything that would have been part of your routine care. So if you would normally have blood work or lab tests or office visits, all of those things have to continue to be covered by your insurance company, even if you're participating in a clinical trial. And that effectively comes out to be just about everything that isn't the thing being tested in the clinical trial, whether that's a procedure or a chemo or a test. And this is a kind of wild and crazy example. It's not a realistic example. If your clinical trial requires something extra that wouldn't have been part of standard of care, then that wouldn't be covered by the insurance. So if the insurance, or if the clinical trial would require you to have a PET scan every week, but standard of care would only be once every 6 months, you would have to pay for the additional PET scans. But sometimes the trial will pay for those additional PET scans. So it's going to be specific to every trial, but you should know that if an insurance company is saying we're not going to pay for that blood work or we're not going to pay for these office visits, that you should be referring them to this law. And this is something that they should be looking at. Because just because there's a law doesn't mean that you're not going to come up against challenges. So I always say if all we needed was a law, we wouldn't need lawyers and we wouldn't need law enforcement. So there's still cases where insurance companies aren't necessarily following the laws, where you have to be on the lookout and be aware of what your own rights are so that you're not having to pay for things that you shouldn't have to. So the last benefit I want to talk about that was created by the ACA was access to free preventive care. So what that means is there's a specific list of preventive services that if you get one of those preventative services on the list, it's entirely no cost to you. You don't have to pay a copayment, you don't have to pay a coinsurance amount, and it doesn't get applied to your deductible. So that means if you go and get your mammogram, then it's totally free to you because that's on that list of services. And that's really been the barrier, is that even though there's coverage for these things, you still have to pay out-of-pocket costs when you go get some of these services, like a flu shot. So people weren't getting preventive care because of the out-of-pocket costs. So the goal to make our society healthier was to make these specific preventive services totally free of charge. And they're the things that you would expect when you go in for a regular annual checkup. So cancer screenings, blood pressure, diabetes, cholesterol, your immunizations, all of those things occur on this list. And I've actually given you the link of the full list that you can go and see what services are included. But I will tell you that healthcare.gov changes their website kind of on a regular basis, and they move things around. So if this link doesn't work, you can still go to healthcare.gov, and in the search box, just put in preventive services, and the list will come up. We're stuck. There we go. We're just slow. So then in 2014, some new protections went into effect. And the first was that it changed the way, oh, I should mention something because it's not in here. So this new benefit of getting access to free preventive screenings, this is specific to private health insurance companies. But there are 3 things that the ACA did for Medicare specifically. So they added 3 new benefits under Medicare. The first is that they added an annual wellness visit, totally free out-of-pocket costs. So no copay, no deductible, no co-insurance amount. Then they also added a list of preventive services that are entirely free. So very similar to what this is for private insurance, they also created for Medicare. Then the third thing was that they closed the Medicare Part D prescription drug donut hole, which is a mouthful. So Medicare Part D, remember, is the part of Medicare that covers prescription drugs. But the way that a standard Medicare plan works is that there's first a drug deductible, which I think this year is $310, that you have to pay out of pocket first. Then Medicare will kick in, and Medicare pays 75% of your drug costs, and you pay 25%, until you get to about $3,000 in prescription drug costs, and Medicare pays nothing, and you pay 100%. And then when you hit your out-of-pocket maximum for Medicare, Medicare will kick back in and pay 95%, and you pay 5%. So that was a lot of numbers to basically say there's a gap in coverage where Medicare expects you to pay for your prescription drugs at 100%. And it's about a couple $1,000s that you'd have to pay out of pocket for your prescription drugs. So Medicare actually and the ACA have closed that prescription drug donut hole, so there isn't a gap in coverage, but they did it over a 10-year period of time. So they started in 2010 when the law was first passed, and it will go until 2020. And each year, what you pay in that gap goes down a little bit, till ultimately you pay 25% for your prescription drug expenses across the board. So, and I apologize that I don't have that slide for you, but I'm happy to include it when I send out the slides. So if you've signed up on the clipboard that's going around, I'm happy to actually send out a copy of the slides for you so that you have this as a resource. This is why talking with your healthcare team is important, because if you can have a conversation with them and say, my insurance, for example, Medicare, is covering me in this way, can I have my injections in the hospital? Then that might be an option. So remember I told you earlier, Part A covers things in the hospital of Medicare, so it's the hospitalization coverage. So if you are in the hospital when you get the Medicare, or when you get your injection, Medicare Part A is going to cover it. If you're at home and you get your injection, Medicare Part D is going to cover it. It's just a regular prescription drug that you're taking outside of the hospital. So Part D is going to treat drugs differently than Part A is. And what you pay for your Part D coverage is going to depend on the Part D plan that you have. So that's why it's also good to look each year, because you might be taking different drugs each year, if your drugs are included in what's called the formulary, the list of drugs that are covered. So I want to come back to the conversation around financial assistance options when drugs aren't being covered fully and what your out-of-pocket costs might be related to those drugs. But I will come back to that. But making sure that you're looking at your formulary list is probably one of the most important things to do when looking at your plan options. So you're going to want to make sure your providers are covered, and then you're going to want to make sure your drugs are covered. And you're going to want to see the prices and the differences in prices between each plan option. So if I wish I had like a chalkboard. If a plan is treating your particular drug as a tier 1 drug, and then the next plan is treating your drug as a tier 3 drug, you're going to have more out-of-pocket costs on the tier 3 drug, because the way that they pay for cost depends on what tier your drug is. So that is going to be specific to every plan. So every plan you look at, you're going to want to see how that plan treats your drugs specifically. So again, it puts more burden on you to make some choices and to do some investigation, but they've given you better tools to actually do that, both for Medicare and for private insurance coverage. And I can show you some of those in just a second. So I just want to speak to this slide very quickly. Insurance companies can now no longer deny you health insurance coverage based on your pre-existing condition, your gender, your age, or any other reason. If you would like insurance and you can pay for it, you can get it now. Insurance companies also can only look at certain things to decide how much to charge you for your policy. So women have always paid more than men for health insurance coverage. That's no longer something they can look at. They can only look at where you live and how old you are and whether or not you use tobacco. But in California, we passed a state law that says we're not going to look at tobacco use at all. So it's limited the way that insurance companies can just randomly say, you were going to charge $5,000 a month for this policy, and you were going to charge $500 a month for this policy. They've leveled the playing field quite a bit. So these two things together have made a huge impact on the cancer community, because ultimately what they've said is, regardless of your medical condition or your medical history, you can't be denied health insurance coverage and you can't be charged more for it. So those two were really game-changing for the cancer community. So the ACA also created 2 new ways to get access to health insurance coverage. So the first was by expanding access to the Medicaid program. And again, in California, we call our Medicaid program Medi-Cal, just to make it easy for us. So Medi-Cal in California, this new category of eligibility is for individuals with a low income level up to 138% of the federal poverty level. So what that looks like for someone who's an individual living alone is $16,243. If you're a family of 4, it's $33,465. So if your household income is below that amount, you get access to Medi-Cal. It's just based on income. It's not based on asset level. And there's no other requirement that you have to meet. It's just based on income. So not every state decided to expand their Medicaid program. California actually did. So this is what it looks like nationally. The states on the left have decided to expand, the states on the right have chosen not to, and the states in the middle are currently discussing it. Although I'll tell you, Alaska's governor a couple of weeks ago actually said he was unilaterally going to decide to expand the Medicaid program, and then his legislature is now suing him. So this is a slide that changes pretty often because things are happening right now very frequently. So the second way that the ACA created a new health insurance option, or a way to get health insurance coverage, is through the state health insurance marketplaces. And the ACA originally called these marketplaces exchanges. So if you hear someone refer to the exchange or the marketplace, they mean the same thing. And in California, we called our marketplace Covered California. So all those names apply to the same thing. Now, when someone goes and buys a marketplace plan, they're actually not really buying a marketplace plan. They're buying a plan from a private health insurer at the marketplace. So it's like going to an insurance shopping mall to figure out what your insurance options are. So that would be like going to the mall and buying a sweater from the Gap and coming home and saying, I bought a mall sweater. You didn't buy a mall sweater, you bought a sweater from the Gap at the mall. So there's a lot of confusion about the marketplaces. So remember that triangle I showed you with you get insurance from an employer, an insurance company, or the government? The marketplace is actually the middle one. You're buying coverage from a private insurer. You're not getting it from the government, and you're not getting it from an employer. So you're just going to the marketplace to buy your plans. So if someone wanted to buy a plan through the marketplace, you might qualify for financial assistance to do that. So there are two types of financial assistance. The first is called a premium tax credit. So based on your income level, they decide how much your premium tax credit is, and it knocks off that amount off your monthly premium. So if you picked a plan that has a monthly premium of $200 a month, but your premium tax credit is $50 a month, you would actually only pay $150 a month for that plan. So it helps lower the cost of your monthly premium. Whereas a premium tax credit actually lowers your co-payments, your deductibles, and your coinsurance amounts for the plan that you choose. So depending on your income level, you might actually qualify for financial help to buy a plan through the marketplace. And this is what it looks like if you're visual, like I am. So if you have a household income up to 138% of the federal poverty level, you have access to Medi-Cal. If you have a household income between 138 and 250% of the federal poverty level, you have access both to the premium tax credits and the cost sharing subsidies. And then if you're between 250% and 400% of the federal poverty level, you have access just to the premium tax credits. So all of this to say is if you have a household of 4 people with an income level up under $95,000 a year, you're going to get access to some type of financial assistance to buy a plan in the marketplace. And that actually covers a large portion of our population across the country. And that was borne out by people signing up for plans last year because 88% of people who bought plans in the marketplace got financial help. So it actually has been able to help a lot of people get coverage. So the other benefit to buying plans through the marketplace are some of these consumer protections. The first is that all the plans sold through the marketplace are standardized. And the way that they're standardized is by their cost share. So remember, way back in the beginning, we talked about cost share being the difference between what an insurance company pays for your medical expenses and what you pay for your medical expenses. So all the plans through the marketplace are named by a metal level. So bronze level is the lowest level of coverage, which is a 60-40 plan, and it goes up by 10 to the platinum level plan, which is a 90-10 plan. So every insurance company that sells plans in the marketplace has to sell a plan under this structure. So you can actually compare a gold plan from company A and a gold plan from company B and know that the cost share is going to be the same and the coverage will be similar, but the price may be different, and who your providers or whether or not your providers are covered might be different. So it helps you compare apples to apples and oranges to oranges when you're looking for your plan options. But one of the most important things to know about the plans sold through the marketplace is there's a cap on the out-of-pocket maximum. So none of the plans sold through the marketplace can have an out-of-pocket maximum that costs more than $6,600 for the year for an individual. So it doesn't mean that they all will be that amount, it just means that they can't be higher than that amount. And that's actually better than a lot of employer plans where your out-of-pocket maximum might be $10,000 or $13,000 for the year. So it's good to know that about the plans, and it's one of the things that you can look for in your plan options. So if you wanted to enroll in a marketplace plan, I've included the information, but the plans are calendar year plans. And so open enrollment will start November 15th, or November 1st this year and go through January 31st of 2016. So even if you choose a plan on November 1st, the coverage won't start until January 1st of next year. So I want to show you this example because this is why it's important to choose among plans. And I'm going to give you an example that actually comes from another state, but the information is the same in terms of how you would go through this process. And it applies the same way whether or not you're buying a private insurance plan or you're looking at your Medicare options. So the math matters. So any plan that you're looking at or multiple plans that you're looking at, you're going to want to actually do the math to see how much it's going to cost you by the end of the year, assuming that you hit your out-of-pocket maximum, which is probably going to be the case. So the way that you figure that out is that you multiply the monthly premium that you pay by 12, and you add it to the out-of-pocket maximum. So for this, I put in a fictitious individual into the system, and I got back three of these plan options. So I chose the cheapest bronze plan, the most expensive platinum level plan, and then I just picked a plan, it's a silver plan in the middle. So the monthly premiums are where the arrows are. So the bronze level plan is $131 a month, but it has a $5,200 deductible and a $6,400 out-of-pocket maximum. Whereas the platinum level plan, it's $510 a month, which is high, but it has a $0 deductible and a $2,000 out-of-pocket maximum. And the plan in the middle is $282 a month, also with a $0 deductible, but a $6,350 out-of-pocket maximum. So you can't look at it on first glance and decide which is actually going to be cheaper. You actually have to do the math. So I did the math for you on the far side. Which plan actually ends up being the cheapest plan at the end of the year? It's the bronze level plan, right? But which one was the most expensive? It's the silver level plan. So every time I've ever done this for any audience, the math has come out differently. And I always pick the cheapest bronze, the most expensive platinum, and one in the middle. And it's never the same. So the moral of the story is do the math on whichever plans you're looking for, because it's going to give you different answers. And it might seem cheaper on a monthly basis, but at the end of the year, it's going to cost you a lot more. And I've done this where the platinum plan has been thousands of dollars cheaper at the end of the year. It just depends on what options are available to you and what you're looking for. So the other thing that you want to look at for every plan, I've said it a number of times, is you want to make sure your doctors are covered, your hospitals are covered, and your prescription drugs are covered. And one of the things that the online system now does is it allows you to check that right from that website. So you don't have to go figure something out. So it has the provider directory, so you can look up your doctors, and it has the list of covered drugs, which is also called the formulary. So the question was, is when you're looking at the provider list, is it by institution or is it by an individual doctor's name? And typically it's an individual doctor's name. However, some institutions will say all of our faculty, all of our providers are covered by X plan. So I happen to know that Cedars actually lists it on the website and says which marketplace plans all the providers at Cedars take. So I think this past year there was an Anthem plan and a HealthNet plan through the marketplace in LA County specifically. But that's been a concern, is that the provider networks have been very narrow. And if you're looking at cancer care and wanting to be able to go outside of maybe your geographic area for care, that again becomes an issue. So making sure before you pick a plan that your providers are covered is the number one step. I've talked to so many people who were so excited to buy plans because they couldn't get one before, and then none of their providers are actually covered. And my question was, well, did you look? And the answer was no. So looking to make sure is going to be the most important part in choosing a plan. Now, I know that also the UC system has limited plan options. So for me, I go to UCLA for all my medical care. And so I had limited plan choices, but I was okay with that because I just wanted to make sure my providers were covered. So it's the same thing, I think, with Cedars also. Cedars actually had a narrower network than the UC system, but they changed that for this year. Last year was more narrow. So we don't know yet what 2016 is going to look like. As we're going into open enrollment, we'll see what all the plan options are and which providers are going to take which plans. So that's not all available yet. So I want to talk a little bit about medical bills because it goes back to the conversation we had before about some of your out-of-pocket costs and how to try to avoid some of them. This is a gentleman talking to his friend, and he says, my doctor told me to avoid any unnecessary stress, so I didn't open his bill. So there are some ways where you can actually lower some of your medical costs before you get care. And again, this depends on the type of care that you're getting, whether it's a surgery or a chemo or another type of prescription drug. But sometimes you can actually negotiate your hospital bill based on where you're going and the rates. Or if you need to get lab work on an ongoing basis, you can actually go to an independent lab to get your lab work done at a much lower rate than maybe wherever your provider is. With Medicare specifically, for the first time in history, they actually started listing what providers were charging and what facilities were charging for certain types of procedures. So I've included the full link on the slide for you to take a look at it. And what they were finding is a hospital next door to the next hospital was charging, tens of thousands of dollars in difference for different types of surgeries or procedures. So we kind of just assume that it costs what it costs, and we pay it, but there actually are some ways to shop around for specific types of medical care if you're willing to do that. And then based on the coverage that you have, you might be able to group your medical appointments together so that you're only paying one copayment to see multiple healthcare professionals. Depending on your policy, you might be able to get mail order prescriptions cheaper than if you were going and getting just a 30-day supply at your local pharmacy. And in some cases, depending on the type of medication you're taking, you can actually take cheaper generic prescription drugs rather than more expensive brand name drugs, but you certainly wouldn't want to do that without talking to your doctor first. And I know that that's a little bit different when we're talking about the specifics of cancer care, but if you're also taking cholesterol drugs or some other type of prescription drug that you might be taking, there may be less expensive options available. But again, you want to talk to your healthcare team. So you also want to talk to your healthcare team about the fact that you might be facing challenges. If you're having high out-of-pocket costs for a prescription drug or treatment, your physician probably has no idea unless you share that information. Now, their billing department or whoever's responsible for billing in your provider's office might have some clue, but generally your physician doesn't. And so you might actually want to have a conversation and say, this is what I'm experiencing, what are my options? Can you help me? If my insurance company's denying, is there a way that you can help me appeal this process? Because providers want to get paid too. So they want the insurance company to pay them. And if you can work together as a team to actually get that bill to go through and have the insurance company pay for it, it's good for both of you. Now, some hospitals actually have financial navigators designated for that purpose specifically, or a social worker or a case manager. That position could be called something different at every facility. So you want to ask your providers to get referrals to those individuals if you need help. But they're also a great source of information. So they might have information about local programs, financial assistance options, discount programs from pharmaceutical companies that can help pay for drugs. So you want to make sure that you're using all the resources available to you. Now, when you get a bill from your insurance company, it's actually typically not just a bill. You're getting a lot of communication from your insurance company. So it could look like this and all happen in order, or it could come out of order. So it could be a letter from your insurance company saying, we've got your claim. So your doctor sent them a bill, and now they're just letting you know they got the bill. Then the next letter could say, we're reviewing your claim. And then the next letter could say, okay, we reviewed your claim, and this is now what we're going to do about it. And that's usually called the explanation of benefits, or your EOB. And it usually says across it in some way, this is not a bill. Don't pay this. So it's just describing what happened. And it's going to tell you what the provider actually billed to the insurance company, what the insurance company is going to pay of that amount, and then what you're responsible for. So they call that the patient responsibility. So that EOB is really important for you to look at because you want to compare it to the bill that you actually get from your provider. Because if the bill from your provider says you owe me $10,000, but your EOB says you only owe the provider $1,000, then you want to make sure everybody's on the same page. And you want to go back and look at what happened. So you want to call your insurance company or call your provider and figure it out. But we're definitely a culture where if we get a bill, we just assume that we're supposed to pay it. And a lot of people just pay the bill without ever questioning if it was right or not. So the next step in the process is actually make sure your bill's correct. It's still a human process. It's not hard to put in 11 and just instead of a 1. So instead of having just one procedure, you've now had 11, and that's what your bill is going to come for. So you just want to make sure that your bills are actually correct before you pay them and compare them to the EOB. It's generally not a good idea to pay the bill until you actually get the EOB so that you can make sure the two match up. Now, there are some professional companies that actually can help you review your bills. So if the amount of bills that you're getting is substantial and it's too confusing to actually wade through, there are people out there who can help you do that. And I've included some resources for you. But you can always go back to your provider or to your billing or the insurance company to ask questions about why things aren't matching up. Now, there's different types of resources in the cancer community about how to keep track of your bills. So there's actually, I think there's a Livestrong planner back there as an example, but that might be an option. Cancer 101 has a notebook that's a good way to kind of keep track of your medical bills and your information, or just your own simple file folder system, whatever works through your notebook. But you never want to throw that away, or any of those bills or communications away, just in case you might need it at some point in the future to kind of refer back to. So I want to actually talk a little bit about some of the financial assistance options that are available. So once you've figured out what you are actually responsible for, the bills that you do need to pay, how do you figure out some of the ways to help you pay it if you feel like that's going to be a challenge? So this is a gentleman talking to his investment advisor, and he says to an investment advisor, all of my money is tied up in futures. Next month's mortgage payment, next week's car payment, tomorrow's groceries. And that's typically, the average person isn't worrying about, serious investments. They're more worried about getting by day to day and paying medical bills, especially after cancer diagnosis. So I promised I would talk briefly about disability insurance as an option. Is there anyone who's receiving SSDI right now? Okay. So is there anyone who's still working? Okay, so then this is relevant. So there's actually lots of different types of disability insurance. So there's disability insurance that you can buy directly from an insurance company, and refer to this as private disability. Or it could be private disability that you get as an employee benefit. So on that first day of work, however many years ago, you filled out all this paperwork, you threw it in a drawer, you never thought about it again, and it turns out that your employer pays for a short-term or a long-term disability plan for you. And if you're ever in a position where you need to take time off work because of your medical condition, your disability insurance is going to pay you your wages. But it's never your full amount of your wages. It's always a percentage of what you are making. So private disability insurance you can buy directly from the insurance company, or you can get it as part of an employee benefits package. But in California, we're one of 5 states and Puerto Rico that offer state disability insurance coverage. So we actually pay SDI taxes to the state so that if we ever need to take time off work because of a medical condition, the state is going to pay us 55% of our wages. So we actually have this benefit that isn't available in other states. It's still relatively small compared to your regular wages, but it's certainly better than nothing. So in California, our state disability insurance program lasts up to a year. So you can take up to a year off from work and have the state pay you. Now, there's also 2 long-term disability programs that are offered by the federal government. There's Social Security Disability Insurance, which is called SSDI, and there's Supplemental Security Income, which is SSI. Now, SSDI is based on your work history. You've paid into the retirement system, and you're effectively getting access to your retirement benefits early because you have a disability and are unable to work. So that's what SSDI is. SSI, you don't have to have paid into the system, but it's based on your low income and your low asset level. So for example, if you have a stay-at-home spouse who never actually worked and paid into the system, that stay-at-home spouse could still get SSI benefits, but they wouldn't qualify for SSDI benefits because they haven't paid into the system. Now, SSI is a flat dollar amount. It's about $860 a year in California because we add a little bit to what the federal government offers. But SSDI, the amount that you get every month is going to be based on what you've paid into the system over your work history. So how many of you have ever seen your Social Security retirement statement? theoretically it's supposed to get mailed to you once a year. They don't always, I feel like I haven't gotten one in at least 4 or 5 years. But you can go online now, and you can create what's called a My SSA account. So you can actually register and get access to your Social Security statement at any time online, which is actually a useful thing to have, because at any time you can look at your Social Security statement and it will tell you exactly what you would get every month if you were to become disabled this year under Social Security standards. So you can actually see what you would get as your SSDI payment by looking at your statement. Now, with the Social Security Administration, they have about the highest standard of disability that any of the laws that I ever talk about have. So they really expect not just that you have a medical condition and it's affecting you, but that it's affecting your ability to work. So I always say when someone's applying for SSDI or SSI, they don't really care that you have a medical condition. They only care that you can't work. So everything that you talk about in your application and your medical records that you're providing to support your application need to speak to your ability to work. So it needs to be, I have this medical condition, I'm experiencing this side effect, it's causing me X, Y, and Z, and that makes work difficult in this way, or impossible in this way. Because they don't really care if work's difficult, they care that work is impossible, that you cannot work, because that's their standard. So you, again, want to frame your argument that you qualify for disability benefits in that same way we were talking about before for health insurance coverage. Now, the first step in the application process can sometimes take a long time. And so the Social Security Administration in 2008 created this program called Compassionate Allowances. And it's a list of medical conditions where if you have one of those medical conditions, you actually speed up your first step in that process. So it doesn't mean that you're automatically eligible for Social Security benefits. It means you're presumptively eligible, meaning that they're going to assume that you qualify because you have that type of medical condition, but they're still going to actually look at your application. It just speeds up that first step in the process. And I've actually included the full list of medical conditions, but right now it includes about 60 cancer diagnoses. Now, the process for applying for Social Security disability benefits is basically set up to deny you. And so more than 50% of the people who apply for benefits actually get denied the first time around. So what that means is you actually should go through the appeals process, because at each stage of the appeals process, your chances go up considerably in getting access to the benefits that you need. So the next step is called a request for reconsideration. So you're really just requesting them to reconsider. Please look at my file again. But if they still say no, then you go to what's called an administrative law judge hearing, or an ALJ hearing. And the ALJ hearing is your first opportunity to sit in front of a live person and say, no, I really can't work. But this hearing and the ALJ process is very subjective. The judge has 100% control over whether or not that judge is going to approve your benefits. And so just to give you a sense of how subjective a process is, I use these stats from 2009 because I can't find another way that it's laid out. But basically, I've given you the top 10 of the list and the bottom 10 of the list. So if you live in Dayton, Ohio, you have a 53% chance of being denied. But if you live in Charleston, West Virginia, you have a 12% chance of being denied. So it's based on the office location of where your appeal would be heard. So in LA County, I think the closest office is Pasadena. So there's an ALJ office there for hearings. So like in Fresno, California, you have a 44% chance of being denied. But if you actually wanted to see it by judge, so you get assigned a judge for your case, if you wanted to see your chances, I've actually included the up-to-date link at the bottom. So you could actually see how subjective your particular judge is and your chances of being approved. Yeah, and I think that's also, it's important that you also tell your healthcare team that you're applying for disability benefits when you ask for your medical records to be sent with your application, because a lot of times You'd always be surprised what healthcare professionals write in your medical records. They write notes. You could be having a conversation about your trip, and they might write something in your medical record about it, even just to help to remember you as a patient. But that all ends up in your official medical records. And oftentimes, what we see is healthcare, like physicians especially, will write patient responding well. And they mean the patient's responding well to like that particular treatment, not that the patient is perfect and fine. But if that's all it says, then it doesn't help your argument that you're having trouble to a point where you're not able to work. And so having that conversation with your healthcare team that you are applying for benefits and actually looking at what your records say and making sure that they're documenting your challenges related to work are all part of that process. So I do also want to point out that there are some financial assistance programs for caregivers who need to take time off work. California is actually one of very few states that provide state-paid family leave. So a caregiver can take 6 weeks off of work and get paid 55% of their wages rather than just having to take unpaid leave. So that program is available in California. And then really looking at finances and how to address the higher out-of-pocket costs that you have is about being creative. So where you can bring in financial assistance in other areas of your budget or your life that can help you free up some money to pay for medical expenses. So thinking a little bit outside of the box. So do you have a supplemental insurance plan like an AFLAC plan through an employer that is going to pick up some of your additional medical expenses? Are you keeping track of your medical expenses during the year so that when you file your taxes, it can actually be a bigger deduction and reduce your tax burden or give you a bigger refund? Do you have a mortgage or a loan or a credit card that has a policy on it that's called a disability waiver premium, which the name doesn't really help you, but effectively what it does is say if you have to stop working because of a disability, they suspend your monthly payments. So you don't have to pay your monthly credit card bills, you don't have to pay your car loan, or maybe even your mortgage payments because you're out of work because of a medical condition. So if your policies have this clause on them, that could be really helpful. But you have to go looking for that information. They're not going to offer it up. So you have to go check your policies to see if this is available to you. And then if you have a 401k plan or some other type of retirement plan, are you able to withdraw money from that plan early to help with some of the expenses? You can either take a loan out. Every plan is going to be a little bit different about the tax implications, but that might be a way to get access to some money in an urgent situation. And then the last thing I want to talk about is life insurance loans specifically. So there's ways to actually sell your life insurance policy, and that's called a viatical. And that could be a great tool for someone who needs access to a larger sum of money to pay medical bills. But generally, viaticals pay very poorly on your policy. So sometimes it's 30 cents on the dollar. So if your policy is worth $100,000, they're only going to give you $30,000. Versus a loan from your life insurance policy, which actually preserves your life insurance policy and can actually preserve some of the benefit of your life insurance policy, which is typically why people buy life insurance policies, while also being able to take some money out of it for needed medical expenses. So there's a lot of companies out there that offer this. We work with Fifth Season Financial a lot because we vetted them, but I've included their information for you to take a look at. But that might be a way to get access to some larger dollars than maybe just a $100 financial assistance program from some of the community-based organizations. Now, there are a lot of community-based organizations that have financial assistance programs. It might come directly from a cancer organization. There might be private companies like Patient Services, Inc. or the HealthWell Foundation, and they all pay different things and they have different requirements. So you can look at some of these programs and figure out if any of them apply to you. So some help you pay your monthly premiums. Some help with you with your copays. Some help with your prescription drugs. So I've actually listed out the specific programs that offer copay assistance, and then I've listed out some that provide prescription drug assistance. But I want to highlight one in particular. And this goes more specifically back to your question earlier, Giovanna, about specific drugs costing specific amounts. So Needy Meds is a clearinghouse for all types of prescription drug assistance programs. So you can go to that one site, pick your prescription drug from a list, and they'll actually show you all of the different programs that are available, whether it's a private program, whether it comes directly from the pharmaceutical company. So Giovanna had asked me about some specific drugs, so I actually did some quick research last night and was able to print out a number of different financial assistance programs. So some of them aren't just financial assistance programs, but they're also navigator programs. So one of the ones that I found on Needy Meds was from Diplomat Pharmacy, has a copay assistance navigator program. And I think both the drugs that you asked me about are on this list. It's a 4-page list of drugs, 6-page list of drugs. But all you have to do is have your someone from your healthcare team complete a form, sign it, and provide annual income information. And then you get not only help with the cost of the medication, but help navigating your insurance company too. So they want to make sure that they're maximizing your insurance coverage first, and then they'll help pick up some of the cost of the copay. So I'm not saying it's a total solution for every cost in the world, but it's a great place to start to find out what some of your options are. And I'm happy to share these, what I printed out with Giovanna, and Giovanna can share it with the group. So then there might also be transportation costs. So there are some organizations that help with gas, with ground transportation. If you actually have to fly out of state to participate in a clinical trial or get care, there's air transportation assistance programs. There's lodging programs. So there's a clearinghouse called Joe's House of all the different housing and hospitality programs for individuals with cancer who need to travel to get to care. And so I've listed some of the links here for you. And then there's all types of daily expenses that you kind of don't anticipate. So if you have young children and you have to go to treatment, childcare expenses, getting access to house cleaning services, utility bills. So almost every utility company has a discount program. Some of them are based on income, but if you can get your utility bills decreased, then you can use that money in other places. So again, it's about kind of shifting some of your budget around to be able to pick up some of these additional costs. And so I've included, again, some of the links for those programs. And I don't know if this applies to anyone in the room, but there's also when people are having challenges paying back their student loans, there's also some opportunities to get some loans forgiven if based on disability status. So I've included that information as well as some general additional resources at the end of the slide deck for you. So again, if you want copies of the slides, please leave me your email address or a mailing address, and I'm happy to send them to you. But I also wanted to share with you that on Triage Cancer's website, we have a health insurance finder tool where you answer basically 6 questions, none of your personal information, but where you live, your zip code, and it will not only come up with health insurance options, but other government assistance programs that you qualify for. So that might be a tool that you might want to use. And then I've included some additional links on our website as well for you. And this is our contact information. So I know I covered a great deal of information, but I also put a lot more into this slide deck for you as a resource for you to be able to walk away with. And certainly you can send us your questions, and I'm happy to stay for a little bit and answer your personal questions if you have them as well.
Thank you, Joanna.
Thank you. Absolutely.
We're in here, and then if people want to sign the clipboard going around, get on your mailing list. And we'll also be including the slides and the video when that's ready, which we'll post online as well. So there's so many great links in your presentation.
I'll also add in, before I send them to you, I'll add in a few of the Medicare specific slides that I spoke to, but that there weren't sort of a reference point for, so that you could actually have.
You also questions by email personally.
Absolutely.
I think we have time for maybe 1 or 2 questions before they kick us out of here. So, do we have any questions?
Yes?
What is the length of COBRA will provide if not able to work or pay the insurance?
So the
Employer.
federal COBRA program, applies to employers with 20 or more employees. So you can actually keep COBRA coverage for 18 months if you leave your job or you reduce your hours. So if you move from full-time to part-time, but they don't offer coverage for part-time employees. But for every other qualifying event, it's 36 months. But California has a law called CalCOBRA, which says that regardless of your qualifying event, or if you work for a smaller employer with 2 to 19 employees, you get to keep COBRA for 36 months. Yes?
Quick question. How often does this happen where insurance company might pay you and then they take back the money?
It doesn't happen very often. It's theoretically possible where an insurance company can approve something, they reimburse you, and then they change their mind and they decide to take back the money. So there's an argument to be made that if you have it in writing where they made a decision to approve something, that they don't get to take back the money. Now, that's health insurance specifically. On the disability side, if you have a private disability policy and you're applying for Social Security disability insurance, there's a 5-month waiting period for SSDI to kick in, but you could be getting benefits from your private company. But then when SSDI does finally pay you, they can back pay you. So if you spend the back payment and then your long-term disability company says, pay us back for what we've already paid you out, then you're gonna owe the disability insurance company. So that would be the only insurance scenario that I could think of where you would have to pay them back. But maybe if you wanna give me more specifics, I'd be happy to talk with you after.
I just heard that this happened to someone who had private insurance. The insurance company paid them and then they requested to.
Oh, so maybe, I'm speculating, that if a insurance company paid a provider, so generally the way that it happens is a provider, like your doctor, sends a bill to the insurance company. The insurance company pays the doctor directly. But if the provider sent a bill, the insurance company paid them, and then also accidentally paid the patient directly, then that might be a reason to get paid back.
I think the patient got paid and then the insurance company wanted some money back. I don't know the details, but.
So without having more information, it's hard to say, but I think generally they're not going to change their mind once they've actually made a payment. They're more likely to say no before they make the payment. But one way to try to alleviate that process is if you have a pre-authorization process or you get approval from the insurance company, try to get it in writing so that if they come back and say, no, just kidding, we're not going to pay that, you at least have the approval in writing.